Right. Good morning, class. This is Dr. Azhar. Right. So I think you guys have started infectious diseases, I believe, um, uh, this week, and you will be going through different infectious diseases in your lectures. So I've given topic today is sepsis and acute diarrhea. These are two different topics, sepsis and diarrhea. So we will treat them as differently as well. Okay. Um, what I think and during sepsis we need to understand that what exactly sepsis is. The first thing, and the second thing you sort of do need to understand is how you recognize it. So what are the important differential you are not going to miss? So I think so we will do the sepsis first. I'm just trying to see on the different screen that whether I can get any learning module on sepsis. Okay, so we do have a module as well. If we can see whether we can go through the module first. Let me screen share so you know what I'm trying to do. Okay. You take its time though. So what is sepsis is? So SIRS is a systemic inflammatory response syndrome. Okay. So it's highly prevalent. It's very expensive. More people die from sepsis than malignancy every year. So sepsis is a systemic inflammatory response resulting from a known site of infection. Severe sepsis is sepsis with organ failure, and septic shock is persistently low arterial blood pressure despite adequately fluid resuscitation. Okay, so let's confirm this. Refractory shock, it happens when, despite of giving inotropic support, patient cannot have increment in his blood pressure. Blood pressure remains low despite vasopressor therapy. So we've learned sepsis, which is a systemic inflammatory response to an infection. We come back to in a minute what is systemic inflammatory response is. Severe sepsis means sepsis with an acute associated organ failure. Septic shock means severe sepsis plus low arterial blood pressure despite fluid resuscitation. Then refractory sepsis, which is refractory to the treatment. So let me see. So what are the learning objectives of this? Let's go through this. Give me a second. हाँ जी, मैं आया हूँ। मैं इस वक्त लेक्चर में हूँ। आपने अगर पेश आना है दिखाने के लिए तो आप इस तरह करें, 12:30 के करीब आ जाए। चले आप 12:30। So our learning objectives here in sepsis is we need to understand the definition of the sepsis. We need to see the various presentation of the sepsis. Risk stratification is very important. How do you investigate the sepsis? How to manage sepsis and when to escalate. So how are you going to manage the sepsis and when to escalate? A subset of the sepsis are neutropenic sepsis and how the pregnancy increase on its effects and management. So let's start the module if we can. Right, so this is going to take us through so pre-test question number one. A 62 years old woman is admitted with shortness of breath following a 3-day history of productive cough that sounds like a chest source of infection. Is the Diapionic saturation is low on room air, hypertensive, and the blood pressure is low, 101/62, and temperature of 36. Okay, so crepitation to the right base says we may have got a pneumonia, and she is not confused. If you remember when we discussed about pneumonia, we do the scoring of the pneumonia, which is a curve 65 score. And the curve 65 score, the C stands for the confusion. So what is her risk of severe illness or death from sepsis? Okay, 62, Diapionic, lowish blood pressure, tachycardic. So does she have an organ failure? Not at the moment. She is not confused. So a death from the sepsis, a moderate to high risk. Which one of the following is the risk factor for developing sepsis? Female sex, diabetes, and spiders, pregnancy is a risk factor. These are tricky questions. I don't know the answers, to be honest. Last time I did this module was in 2018 or something like 17, I believe. Okay, so 65 years old woman has central venous catheter inserted for parenteral nutrition. So she had a CVP for nutritional purposes. She was having a fever, tachycardic, white cell and CRP quite high. So what the most important investigation you will perform first? Blood cultures, line tip cultures. So first of all, you do the blood cultures. Chest rate, you all do probably all these apart from thyroid. But the first important thing is to do is the blood culture. So remember, in sepsis, the blood culture is so important. A 72 years old man is admitted to the emergency department with shortness of breath and productive cough. Again, a sepsis. Respiratory rate is 25, but a systolic blood pressure of 89, and he is confused. So this patient is confusion, low blood pressure, and sepsis. So what is the best description of this condition? So the source of infection is chest. Okay. I would say this patient is in severe sepsis because of organ failure. 75-year-old woman diagnosed with severe leg cellulitis. Okay. Blood pressure is lowish, not confused, not passed urine in the past 24 hours. Blood tests and blood cultures are taken. What is the next? Remember, fluid resuscitate, intravenous antibiotics. What would be the next step? Either intravenous, I think intravenous resuscitation is important. Intravenous antibiotics. After blood test, you give intravenous antibiotics. Don't delay for the fluid resuscitation. Right, a 62-year-old man is admitted with shortness of breath. associated with a productive cough, right? Chest, past medical COPD. He's a CO2 retainer, so he tends to have a type 2 respiratory failure. He's hypoxic, but 88, which is okay for a COPD. Tachyphonic, high temperature, tachycardic, and lowish blood pressure. So you take the blood cultures, you administer blood straight, you're informing the registrar who is happy with your current management, is currently performing the central line. You also perform an ABGs and serum lactate was high as well. What do you do next? So what is this? So you give Hartmann over less than 15 minutes. So give stat Hartmann of 500 mils. So give a bolus of fluid challenge. So a 40 years old woman is with septic shock, severe sepsis plus low blood pressure, intra-abdominal infection. She developed C. diff, secondary to antibiotics, and she cannot remember the name of the antibiotics. What is the most appropriate option for antibiotic therapy? She has a history of previous C. diff associated with antibiotics. It's in septic shock, so you just give broad spectrum antibiotics. "67-year-old woman is brought to a local hospital without emergency surgery services at 6 a.m. on Sunday. She is found to have perforated sigmoid diverticulum and free intra-abdominal fluid. She is currently stable with no organ failure. The nearest emergency is 30 miles away. What is the most appropriate step? Antibiotics and fluid. So early broad spectrum antibiotics with transfer to an emergency surgery only if clinically deteriorates. 25-year-old man is receiving chemotherapy for testicular cancer. Now it's a neutrophilic sepsis. So low neutrophil count, high temperature. Rhinovirus is positive. So you administer an empirical antibiotic, broad spectrum antibiotic in all neutropenic septic patients. Okay, so 45-year-old woman is administered with a right iliac fossa pain following a recent appendectomy 2 weeks ago. So all these 10 questions which we have done, they are actually are all septic patients, and there are different areas of management where each question is focusing, and shortly we're going to review in details. That's what the whole module means. So she has a respiratory rate of 24 breaths per minute, oxygen saturation of 94%, hypertensive, hyperthermic, tachycardic. So she probably has got a post-operative complication. She is hypoxic as well. Tender. So she has got a high risk of developing sepsis. So post-wound infection. So So there are 4 cases. So let's have a defined sepsis. Sepsis was redefined by sepsis 3. Okay. Life-threatening organ dysfunction caused by dysregulated response to immune. So life-threatening organ dysfunction caused by dysregulated host response. So previously we learned that it is the SIRS response to the infection, which is called sepsis. But we have come out of it now recently. This is quite recent actually. This is after 2016. The new sepsis 3 definition is life-threatening organ dysfunction caused by dysregulated immune response. A dysregulated immune response. So organ dysfunction is defined as a change of 2 or more points in SOFA score. The SOFA score is a quick SOFA score at the bedside. So if the score is 2 of the quick SOFA score, sepsis is likely. Sepsis is persisting hypotensive, requiring vasopressor to maintain the mean arterial pressure at 65 above and having a serum lactate level of 2 despite adequate volume resuscitation. Severe sepsis terms that should not longer be used. A third international consensus group felt it was now redundant because it changes to the definition of sepsis. So let's see what is the Q-SOFA score. The Q-SOFA score is altered mental state, systolic blood pressure is less than 100 and respiratory rate of more than 22. So any of the two. So the diagnosis of sepsis can be confirmed if this is required by subsequently performing the full SOFA score compared to the patient's baseline if available. So you risk stratify them by using this tool. So why this systemic inflammatory response? So what was the SIRS response was? So 2 of the following, so temperature, heart rate, right respiratory rate and white cell counts. So white cell counts and temperature. SIRS with, so previous definitions were these. So SIRS was focusing on inflammation. So there are quite a bit of problems with the SIRS. That's why they have come away from the sepsis. Okay. Right, so let's do the case history first. So 65 years old right teacher is admitted with the hospital with a 5-day history of earthquake cough on arrival, emergency, confused. So confusion is there and the patient is tachypnic. Blood pressure is low, heart rate is 1.3. A chest radiograph shows evidence of left side pneumonia. She has not received any treatment. Which one of the following definition most accurately describes the patient's clinical condition based on knowledge of so far? So patient has got sepsis. The Q-SOFA score is more than 2 plus low blood pressure. So again, organ dysfunction is defined as change of 2 or more points. So organ dysfunction. Okay, and what were the Q-SOFA score was? Altered mental status, systolic blood pressure. So these are the 3 things in the Q-SOFA score. Okay, so why? So that's correct. So we will see it. So answer number two, answer number one. So the patient is likely to have. So this patient has a community-acquired pneumonia, progress to sepsis. The sepsis is now defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. So although this patient is in sepsis, okay, septic shock, so low blood pressure, but septic shock definition is now a hypertension which persists despite fluid resuscitation. So you resuscitate the patient, and then if the blood pressure remains low, and what is the low blood pressure? It is the mean arterial blood pressure lower than 65. And if the serum lactate is more than 2. So septic shock is different than sepsis. As we have told you before, the definition has moved away from the cells. So patients who are at risk of sepsis, so you risk stratify them. Okay. So now, you identify the patient is likely to have sepsis secondary to community-acquired pneumonia. You commence oxygen. You give intravenous fluids. Now you want to risk stratify the patient. Whether it's a low risk or high risk, moderate risk. Her observations were 25 tachycardic, remain blood pressure, level of consciousness confused. So what is the scoring? So respiratory rate more than 25 is 3. Oxygen saturation less than 91 is 3, 6. For COPD is different. Patient is not on supplemental oxygen therapy. Temperature is 0 score. Patient systolic blood pressure is less than 93, 33639. Heart rate patient is tachycardic, 211. Patient is confused, 314. So patient score is 14. So that's how you calculate the score. So that is very important. So patient news score. So this is called as early warning score. So the news score is more than 7. Patient is at significant risk of mortality. And this should prompt emergencies. So risk stratification. Under the NICE are divided into 3 broad categories. So there are red flag sepsis, amber flag criteria, sepsis screening tool. That's how you deal with sepsis. Some are the red flag, some are the amber flag. So it depends which flags are there and you re-stratify them. Okay. So news was high, you call the critical team and assess an equally quick sick patients. They advise you to continue the management as per the diagnosis of sepsis and ensure all investigations and treatments are performed. What is the most first important investigation to arrange first is blood cultures. So peripheral blood culture remains the cornerstone of the identifying the sepsis, re-stratifying the sepsis, and treating the sepsis. In the patient of the previous MRSA, you do the MRSA screen. Identification for pneumococcal and non-pneumococcal pathogens, you do it as a part of investigation of sepsis. So blood cultures, you do. At least one set should be taken percutaneously and one set should be taken if there is any vascular access is present, like central line, PICC line, and should be taken before antibiotics administration, but don't delay the administration of antibiotics because of blood cultures. Routine blood count, serocreatinine, CRP, and clotting screen you do. So that is the investigation of sepsis. Clotting screen, urea electrolytes, thrombocytopenia, they also feature of sepsis, full blood count. So blood gas analysis, ABGs. Serum lactate level is very important. A lactate level of 2 or more is a poor prognostic indicator, and if 4 is even worse. Serum glucose level. So glucose may be elevated. Hyperglycemia is associated with increased mortality. You check urinalysis for any infections. You do a chest X-ray. All patients of sepsis. You do an ECG. Other cultures being urine, sputum, cerebrospinal, pleural fluid. Wherever there is a fluid, you take a culture. Lumbar puncture if necessary. Ultrasound scan for abscesses, free fluids, and sometimes you do a serum, a CT scan and procalcitonin level. It's a precursor of calcitonin, which is responsible for calcium homeostasis. It is gaining support for its clinical use as a clinical biomarker between sepsis and the inflammatory SIRS. SIRS is still used to describe a non-infectious causes of inflammatory states. So the patient diagnosed with sepsis subsequently community acquired pneumonia and commenced oxygen via venturi mask. And what next? Blood cultures were taken promptly. A sputum sample is also provided to the microbiology. Which was the following only evidence-based treatment that has shown to reduce the mortality in sepsis? So antibiotics have shown only antibiotics reduce the mortality. Sepsis 6. What is sepsis 6? So this is very important. You give oxygen. So target oxygen for patients who does not have any pre-existing lung disease is 94 to 98%. And patients who do have a pre-existing lung disease and they are at risk of CO2 narcosis or CO2 retention, their target oxygen therapy is 88 to 92%. Blood culture should be taken as soon as possible. Intravenous antibiotics, intravenous fluid resuscitation, lactate levels to check, and monitor urine output. This is sepsis 6. So give oxygen, take blood cultures, give antibiotics, give intravenous fluid resuscitation, check the lactate levels, and monitor the urine outputs. So our was antibiotic. Okay. So let's go to the case 2. So 32 years old a woman who is 6 months pregnant, turns the emergency, feeling generally unwell, burning and stinging when passes urine. So possibly we've got a UTI with vomiting, past medical history of cholecystectomy, gestational diabetes during the pregnancy. So she is diabetic due to pregnancy. She has got probably a UTI. She appears breathless, clinically unwell, and you suspect diagnosis of sepsis. So what are the sepsis risk factors? So strong risk factors: malignancy, age older than 65, age younger than 1, immunocompromised, hemodialysis, alcoholism. So these are all the risk factors. Diabetes, pregnancy. Recent surgery, drug abuse, burns, cuts, blisters, end-of-wearing catheters. They're all risk for sepsis. Weak risk factors are non-white, male, lung disease, urban, obesity. Risk factor for sepsis in pregnancy. So what are the pregnancy risk factors for sepsis? Obesity, impaired glucose tolerance, so diabetes, obesity, anemia, any discharges, vaginal, streptococcal infections, previous C-sections, wound hematomas. So these are all risk factors for developing sepsis. Which of the following have increased the patient risk of developing sepsis? Tick all that apply. Pregnancy, gestational diabetes, so this is all about the risk factors. So gestational diabetes is a recognized risk factors, whether type 1 or type 2. Female sex is not a risk factor. So if someone has got surgery in the last 6 weeks, they are at risk of sepsis. But the previous history of sepsis before 6 weeks, no increase in the risk. Age is 75 or above is a risk. You go on to assess the patient, you do airway breathing, ABCDE, disability, pupils equal, capillary glucose 10.1, circulation, blood pressure, saturations. The baby heart rate is 150 and use has not been validated in pregnancy. You decide to use a nice risk stratification criteria to determine the prescription risk. Risk stratification. So this is the National Early Warning Score criteria. So early warning scores are based on the physiological parameters, okay? So changes in these physiological parameters give you early warning score. A new score of 5 or more is likely to represent a sepsis. Nice criteria for patients: high risk, moderate risk, and low risk. Okay. So these are the risk stratifications. I don't think so whether you can see it or not. So you just have to risk stratify these patients. So how would you categorize the patient? So this patient is probably has got a moderate to high risk. Okay. They categorize the patient as low, moderate, or high risk. Several moderate to high risk criteria, referred to as amber flag criteria. So respiratory rate was 24, heart rate was high. So moderate risk criteria is 90 to 100 to 130. Signs of potential infection. There are also no high risk criteria present. The patient is diagnosed as being a moderate to high risk sepsis. Sepsis 6 Bendel you give. Which of the following the most appropriate Trex first step? The just shows serum lactate. Give fluid challenge and inform the critical care. So this patient is very unwell. So you know the lactate of 4 is highly pathological and carries a worse prognosis. A high lactate correlates with a poor prognosis, particularly if it's above 4. So lactate also indicates a level of tissue hyperperfusion, which suggests the blood pressure is low. It would not be appropriate to leave the patient at this point and review after 15 minutes. It would be appropriate to give IV fluid and inform the team. So the patient was transferred to the intensive care unit, given IV fluid management, IV antibiotic, and checking the serum lactates. Okay, so the 75 years old has been admitted for an emergency nephrotomy for large bowel obstruction, secondary to new diagnosis of bowel cancer. Okay, the critical care outreach team is called. On arrival, the patient is sweaty and febrile. Blood pressure is low. Diagnosis of suspected blood culture are taken. Antibiotics are given. ABG shows serum lactate is high. Hemoglobin is 8.1. So, what is the most appropriate next step of management? So, you give fluid challenge. The 66 bundles pathway should be started. So you give fluid challenge, the rest of the things were done, and you monitor the kidney output. So 500 mils of bolus of IV saline were given. An emergency abdominal CT scan is therefore arranged. Patient is now confused, so is further deteriorating with a low blood pressure. So you urgently admit the patient to the intensive care. So which is incorrect, so you probably will do emergency nephrotomy because the patient, so source control is major pillar of the treatment. So treat the infection. If I don't take it, patients to them. So within 6 to 12 hours, definite treatment for this should be given. Peritonitis is a result of leakage, large bowel anastomosis, which needs urgent closure. Supportive care along with intensive care would not be sufficient to treat this. This patient needs to go to the theater. That's the most important thing. That's the learning bit. Okay. So following the operation, the patient is brought to the recovery area. He requires 80% of oxygen to maintain oxygen saturation and is a non-adrenaline infusion. Large volume of fluid has been given, only small amount of urine is passed, lactate concentration is around 3. What is the most important next step in the management? Admit the patient. This patient may have got acute kidney injury as well and is requiring high level of oxygen. And you monitor cardiac output. Continue with antibiotics. His mean arterial pressure is low. So that's what probably you do. So there is insufficient evidence that patient needs a renal replacement therapy. Patient does have got an acute kidney injury, but patient doesn't need a hemodialysis therapy now. If it needs, it will need a continuous hemofiltration rather than intermittent hemodialysis. So let's go to the continuous, go to the 4. So that's about the neutropenic sepsis. So 42 years old woman with rheumatoid arthritis has been admitted to the hospital. 24 so she has got pyrexia. So what is the most severe provisional diagnosis? Generally unwell. Eichmann line is situated there. So this patient may have got neutropenic sepsis and sepsis. Important. So this patient was on chemotherapy, and after chemotherapy developed inflammatory response. So this is sepsis 3 definition. So what you do, so you need to take the blood cultures from the Hickman line. So again, cultures are the first most important thing. So I think I'm going to close this module now, and we're going to quickly go through the diarrhea thing. Okay. So let's do this diarrhea. So what is the acute diarrhea? So diarrhea, so what's the definition of diarrhea? True diarrhea is an increase in the stool weight to more than 250 grams in 24 hours. So 2 loose stools, small 2 loose stools is not diarrhea. The acute diarrhea is onset is sudden and is less than 14 days. Infectious causes, contaminated food remains the most important infectious cause for the diarrhea. Bacteria, Staph aureus, E. coli, Campylobacter, Salmonella, Shigella can cause. Viruses, rotavirus, norovirus, they can all cause diarrhea. Fungal infections can cause diarrhea as well. Parasitic infection can cause dietary, sometimes sorbitol in the food, or they're allergic to milk, they can cause diarrhea. And sometimes chemical poisoning. And drugs. So how do you diagnose? The diagnosis of acute diarrhea can be made by history and physical examination. History, you check the onset, duration, amount and frequency of blood in the stool, pus in the stool, mucus in the stool. All these questions needs to be asked from the patient. What are the symptoms associated with the diarrhea? Any fever, any abdominal pain, nausea, vomiting? These questions needs to be asked. Any drugs or dietary intake, any change and major changes in the dietary intake which could contribute towards this diarrhea. Signs for dehydration, temperature and abdominal tenderness. So if you do the different Staphylococcus, E. coli and Bacillus, these are the immediate infective organisms. So Staph aureus and Bacillus can cause a rapid onset with diarrhea, vomiting. Stool and food culture, recovery within less than 24 hours in Staph aureus. Bacillus cereus can take some times, and if it's the E. coli, which takes 12 to 48 hours, it can take 10 to 12 days for the recovery. Clostridium perfringens or Clostridium botulinum will take a day. It can take a diarrhea, crampy pain, diarrhea and paralysis. So culture organism in feces and food, and Clostridium botulinum is and the toxin in the food. 10 to 14 days it takes. Salmonella A blood diarrhea, vomiting, stool cultures, where it can take up to 12 to 2 weeks to recover. Campylobacter jejuni, diarrhea, blood, fever, malaise, stool culture 3 to 5 days. Shigella, again stool culture 3 to 5, 7 to 10 days. Contaminated food. Causes of several diarrhea is bacteria, which can cause by Shigella, Salmonella, and viruses. Proteus are low. So management is, if there's a diarrhea, no systemic signs, symptoms, stool cultures are not needed. Systemic illness, fever, bloods lasting 2 weeks, dehydration, food poisoning outbreaks. So you admit the patient or oral fluids, presume microbial therapy. If there is a white blood cell scenes, the likely culture will be Shigella, Campylobacter, or E. coli. Likely culture, again C. diff and E. coli. A parasitic scene will give us specific therapy. So that was symptomatic treatment. Adults and older children should drink sufficiently quantity of fluid. ORS can be given in the infants. Intravenous fluid can be given if the patient is unable to maintain oral intake. So adsorbents. Self-limiting doesn't require any treatment. Cipro is the main for Shigella, Salmonella, and Campylobacter and E. coli. Doses can be different. Parasitic infection, you give a metronidazole. Okay, so this was a bit about the diarrhea. So the main causes of acute diarrhea are what we have learned here: Staph aureus, E. coli, Bacillus, Clostridium perfringens, Salmonella, Shigella, and Campylobacter. So Salmonella, Shigella, Campylobacter, Clostridium, they can all, Staph aureus, E. coli, they can all cause acute diarrhea. Acute diarrhea is happen when it is less than 14 days, and diarrhea definition is increased amount of stool which is more than 250 grams. Any questions needs to be asked? Okay, I'm going to leave you in peace for now, and thanks for listening.